And that's not in the way of your face.
No, you're good.
No, you just pass it. Thank you. It's okay.
All right, good morning. Let's go on with the pathophysiology of breast cancer before we get into the drugs. Okay, we've mentioned the fact that the precise etiology of breast cancer is not known, but just like every other cancer, it has to do with genes. So there's a genetic component to the incidence of breast cancer. Now the body actually has some proto-oncogenes. That is, those genes that if you activate can actually lead to the growth of breast cancer cells. Those proto-oncogenes are what you call the MYC genes, the ERB two genes, which is actually about the same as your HER2, the human epidermal growth factor receptors. And then the cyclin genes, the ones that can help to produce your cyclin-dependent kinases. Okay, so once those proto-oncogenes are activated, then you can see the rapid growth of the normal somatic cell, which has been modified to become a cancer cell. And as usual, the body tries to maintain balance, or what we call homeostasis. So as you have proto-oncogenes going forward, the body produces some suppressor genes that can suppress the activities of your oncogenes. And so we have some suppressor genes, and these three are the prominent ones in terms of breast cancer: the P53 gene, the BRCA1, and BRCA2 genes. And of course, BRCA there simply refers to breast cancer. Okay, so breast and then cancer. Even though it's called BRCA, those two genes are also involved in prostate cancer, so it's not just breast cancer. Okay. So if you have a decrease, or if you have a malformation, in which case we will say mutation, so if you have a mutation of your suppressor genes, then the chances of breast cancer developing will be increased. So either an increase in the expression of your proto-oncogenes or a decrease in the expression of suppressor genes can increase your chances of getting breast cancer. Now, that mutation can, of course, let's take, say, BRCA1 or P53. A mutation of that gene can occur when you have a somatic transformation of the cell, that is, of the breast cancer cell. But you can also see it when it is transferred along germline. That is transferred from mother to daughter, and so on, So familial or inherited type mutation. And if that happens, you can see what we refer to as G, BRCA, N. That means mutation of the BRCA gene that is transferred along germline. So the G stands for that germline, and then BRCA gene, and then mutation. Similarly, we have some that we will call S, BRCA M type of breast cancer. In other words, mutation of the BRCA gene that developed from a somatic change or a change in the somatic cell in the body. Okay, so if you see G BRCA M or S BRCA M, that's what it's referring to. Okay? If it's transferred down the germline from mother to daughter, it will be G BRCA M. If the individual just happens to, let's say, be exposed to ionizing radiation and then develops a mutation in that BRCA gene, then that will be a somatic BRCA M type of breast cancer. Okay? genes that are involved in the development of breast cancer. Whatever changes the normal somatic cell to become, malignant or, cancer type cells, that will be an initiator. Okay. So it's something that initiates or starts the transformation of your normal cell into a cancer cell. Once that initiation occurs, then you will have a promoter, something that will promote the ongoing proliferation of that cancer cell. Now, estrogens, an estrogen is considered to be a promoter, So under the influence of estrogens, the transformed cells can produce some growth factors, like your transforming growth factor alpha. Transforming growth factor alpha, then your epidermal growth factor, your insulin-like growth factor, or your vascular endothelial growth factor. Okay. Even the platelet-derived growth factor. So under the influence of estrogens, the cells that have been transformed from normal to abnormal, that is to the cancer cell in the breast, will be producing these growth factors. Okay, and that's why those cancer cells will be proliferating, because they have the growth factor. Again, homeostasis, the body tries to counter those by producing a transforming growth factor beta. Transforming growth factor beta opposes what you see with these growth factors that are promoting the growth. So transforming growth factor is an inhibitory factor. All these other growth factors are stimulatory. That is, they increase the proliferation of your transformed normal cell. And then, of course, we have prolactin, follicle-stimulating hormone, and luteinizing hormone. All of those can also increase the proliferation of that transformed cell. That is, so you can see more of your breast cancer cells growing. Okay, so those are all the genetic input into the production of your breast cancer. And how would you diagnose breast cancer? About diagnosis. One, of course, would be the self-exam. That is the self-examination of the breast. You should feel a lump, and the lump would be solid, of course. It will be solid, and it will be rough at the edges, so it will not have a smooth edge. It will be rough in terms of what the edge looks like. And usually it is stationary. It just stays at that one spot. So that's one way of beginning to diagnose the occurrence of breast cancer. And two, you can use imaging system of the breast cancer. And for imaging, you can use ultrasound ultrasound can help in the diagnosis. Or you can use MRI, magnetic resonance imaging. Okay, so you can use that. And then, of course, mammograms. Okay. And for the mammograms, you have the old type of mammogram that just exposes the breast to all this radio imaging. And then you have the digital mammogram, which is more specific and uses less radioactive or rays. And then you have what is called breast tomosynthesis. And breast tomosynthesis is actually a 3D imaging. So it is clearer, it uses less radioactivity, and it actually takes layers of the breast that is affected. So it is more diagnostic, if you will, than the old mammograms and the digital mammograms stuff. So that is the preferred one today, the breast tomosynthesis. So you get a 3D image of the breast that is affected. Okay. So apart from the imaging, you can then use biopsy in the diagnosis. The old biopsy where you actually cut open the patient, you have some better methods now that one can use. So we'll just say this is old biopsy right here, which is very intrusive, okay, because you have to cut open that chest. Now you have the fine needle system, that is called fine needle aspiration. So a very fine needle is just threaded through the breast to take a sample of the cancerous tissue. So fine needle aspiration, if you ever come across what they call FNA, that's what it means, fine needle aspiration. Okay. And the one that is preferred today is the mammotome. The mammotome is far less intrusive. There's a digital program that can direct the doctor so that he can guide the probe of that mammotome to the cancer, and then you can have a less painful extraction of the tissue. Okay. So, and that can be done in the doctor's office. Only takes a few minutes. Not painful, nothing. And so you can extract the tissues that way. So if you're looking at diagnosis, those are the three modalities of diagnosis that are often used. And then sometimes you can see people do an assay of the cells to determine if they have hormone receptors, if you will, and they can characterize those hormone receptors, whether they're ER or PR, or whether you have a HER2 receptor, because that would determine the class of drugs you would go to manage the breast cancer. And in terms of treatment, you have three modalities of breast cancer treatment. One, of course, would be radiation. You can use radiation to kill off some of those breast cancer cells. And then two, you can use the surgical method. For the surgical method, of course, you can have just lumpectomy. So just that little lump is excised or taken off. Or you can use quadrant excision, where you take off a little more than that lump, maybe surrounding tissues. That would be quadrant. Segmental mastectomy you're taking off more than what you took off in quadrant excision. And then you can have a full mastectomy, where you just take out the entire breast. Okay, that would be full mastectomy. Sometimes segmental is called partial. That's another term you can see. Partial mastectomy is the same thing as segmental mastectomy. And then modified radical mastectomy, that means you take off the entire breast, okay, and you also take off the axillary nodes as well as the pectoralis nodes. And the pectoralis nodes you divide into two, major pectoralis and minor pectoralis. So a modified radical is the axillary nodes and the minor pectoralis nodes. So that would be modified radical mastectomy. But in the full radical mastectomy, you take out the breast, you take out the axillary nodes, and you take out both pectoralis nodes. That is both major and minor. So it's just removing everything. So that would be surgical means of handling the breast cancer. And now we can start with what concerns us, and those would be the drugs that you use in managing breast cancer. So we'll start off with your PARP inhibitors. The poly-ADP ribose polymerase inhibitors. Okay, and we'll take olaparib as the representative agent of that group. Of course, we mentioned your PARP inhibitors in the past. Okay, so you can talk about elaparib and talazoparib, olaparib, niraparib, and ricaparib. So we can go back and look at the drugs that are involved in that class, and I think there's still also your new handout. So we'll take olaparib as the representative agent, and as usual, we'll start with the mechanism of action. The mechanism of action is in the classification of the drug, so it would inhibit your PARP. And why is inhibition of the PARP necessary or important? It is because that enzyme is involved in DNA repair. So it's involved in DNA repair. It is also involved in transcription. And it is also involved in the normal function of your cell cycle. Okay, so if you inhibit it, then of course the cell will not be viable. So that's why your PARP inhibitors can cause the death of those cancerous cells. So that's in terms of its MAO. In terms of the acne, we know that the drug is administered orally. You have about 3 different strengths, the 50, 100, and 150 milligram strengths of your olaparib. And when it is given orally, the patient has to avoid your grapefruit juice. Okay, so they should avoid grapefruit juice and some type of orange, that is called silver oranges, because those can basically increase the plasma concentrations of your olaparib, such that you will have a greater incidence of adverse effects. Okay, and in terms of its distribution, it has a half-life of about 15 hours. Okay. And so that explains the BID administration of the drug. So whatever strength you give will be administered on a BID basis. Okay. In terms of the plasma protein binding of olaparib, it is about 82% plasma protein bound. And the metabolism is by your 3A4. So it is a substrate for cytochrome P450 and that's where you have drug-to-drug interactions with olaparib. So any drug that stimulates 3A4 will decrease the effectiveness of olaparib, and any drug that inhibits 3A4 will increase the plasma levels of your 3A4. Okay. Now, olaparib itself can inhibit 3A4, and it can also stimulate 3A4. Okay. And it also happens to stimulate your 2B6. Okay. So you see you have different avenues for drug-to-drug interaction when you give olaparib. And in terms of the excretion, it is about equally excreted through the feces and through the urinary system. Okay. It's about 44% through the urinary system, and it's about 42% through the feces. Okay, so it's almost equal in terms of renal or fecal excretion. Now the indications for your olaparib so it can be used in the treatment of breast cancer. Of course, that's the one we're talking about. It can also be used for the treatment of ovarian cancer. It's also effective in managing prostate cancer. It also works against pancreatic cancer. So in terms of breast cancer, you use it in the management of your S. BRCA as well as your G. BRCA. But that is after the patient has been treated initially with chemotherapy. Okay, so a patient that you give olaparib, for the management of their breast cancer must have received prior chemotherapy. And then you can use olaparib as a single agent to maintain the management of that breast cancer. And it is effective in cancers that are HER2 negative. Okay. So you only use olaparib when you have a metastatic cancer, that is severe or serious cancer, that has HER2 negative in terms of the receptors that it binds to. Okay. But remember, it is after an initial therapy with chemotherapy with drugs. So those are the indications. And then for adverse effects of olaparib, it has a lot of GI-related adverse effects, and those are very prominent. And those are what we call RNBD. Okay. Of course, that's nausea, vomiting, diarrhea. The A here is anorexia. Anorexia, dyspepsia, and dysgeusia. So anorexia, dyspepsia, dysgeusia, nausea, vomiting, and diarrhea. Those are very prominent adverse effects of olaparib. And then it affects the pulmonary system a lot. It can cause the swelling of the lungs. It can cause the swelling of the lungs, and you can also see an increase in the incidence of upper respiratory tract infections. Okay, so the patient might experience sinusitis, some pharyngitis, sometimes cough, will be present, shortness of breath can be present, in the patient that is taking the drug. Bronchitis can be a manifestation there. So it affects the pulmonary system a whole lot. And then it can actually cause pulmonary embolism. So clotting, the vessels that support your pulmonary system. So pulmonary embolism can be observed there. GI and pulmonary symptoms are the two primary organs or tissues that your olaparib can affect. Now you can also have a drop in magnesium, so hypomagnesemia can be seen with this drug, and it may also affect the bone marrow a little, so you can get anemia. The anemia may be responsible for the overall weakness that the patient feels. They feel fatigued, they have muscle weakness, during therapy with olaparib. So all of those may probably result from the anemia that it can generate or produce. Like we mentioned earlier, any drug that you use to treat cancer could also cause cancer. So olaparib can actually produce primarily acute myeloid leukemia in certain patients. Acute myeloid leukemia. And it has also been known to produce MDS, myeloid dysplastic syndrome, which is actually a type of cancer also. And apart from this PE that you see, which relates to clot, it may also produce venous thromboembolism. So it can cause clots, not only in the pulmonary system, but also just in your venous system. So those are the adverse effects of inhibitor, particularly olaparib. Okay. Another class of drugs that you will see used in breast cancer would be the cyclin-dependent kinase inhibitors. The cyclin-dependent kinase inhibitors. We'll use Abrams as the representative agent for that group. Okay. And for the mechanism of action, of course, it would inhibit CDK4 and 6. Okay. What do kinases do? Kinases tend to phosphorylate other substances. They add the phosphate group to it. There's a protein that is called retinoblastoma protein. This is a protein that tends to direct your cell cycles to begin. It makes the cell cycle go from G1, that is, it enters a replication cycle. Okay. So normally you will have the pre-mitosis, and then you will have mitosis, and then you will have two brand new cells or daughter cells. That's usually the way your cell cycle goes. The movement from G1 to S requires that retinoblastoma protein in the phosphorylated form. Okay. It has to be phosphorylated to be active. Okay. And your cyclin-dependent kinase, of course, an enzyme that causes that phosphorylation. So if you inhibit that kinase, there will be no phosphorylation of retinoblastoma protein, and if there's no protein here, then there will be no signal for the cell cycle to move from G1 to the synthetic phase or the S phase. And so that's how your CDK inhibitors work in breast cancer. Okay, so they inhibit that CDK4/6. By that inhibition, there will be no phosphorylation of the retinoblastoma protein. The retinoblastoma protein is not phosphorylated. It's not active, so it cannot direct the cells to move from G1 to S. Without that, the cell cycle is arrested. So there's no proliferation of the cancer cell. Okay, so that's the mechanism of action there. In terms of the admin for your Abrams, we know that it can be administered orally, and of course you have different strengths there. 75, 100, 125. Even though 125 is the highest strength, it is the strength that you actually start treatment with, you know, when you are using Abrams. Okay. So, like we mentioned under the PARP inhibitors, grapefruit juice can also affect the plasma levels of your Abrams. St. John's wort can decrease the plasma levels of your Abrams. So those would be two things to be conscious of. Abrams should not be used in a patient who is breastfeeding, and it should not be used in a patient who is pregnant. Okay, so those are cautionary statements for your Abrams. Okay. And we know that when Abrams is used, it has to be combined with your aromatase inhibitors or with fulvestrant. The aromatase inhibitors would be inhibitors of estrogen synthesis. Fulvestrant or Faslodex will be an inhibitor of the receptor for your estrogens. Okay. So it has to be used in combination with those agents. And the aromatase inhibitors that are often used with it will be anastrozole. Anastrozole will be one. Letrozole is another that is used. And then exemestane is another one that is used. If you use anastrozole, you'll be using 1 milligram of anastrozole with the Abrams. If you use letrozole, it will be 2.5 milligrams. And if you use exemestane, it will be 25 milligrams that you will use with your Abrams. And the way the regimen is administered is on day 1 to day 21, you use a combination that is Abrams plus an aromatase inhibitor. Okay? And then on days 21 or 22, if you will, to 28, you give only the anastrozole, only the aromatase inhibitor. So days 1 to 21 will be the combination, Abrams plus the aromatase inhibitors, days 22 to 28, it will just be the aromatase inhibitor only. Now, if you use Faslodex, we'll be using 500 milligrams of the Faslodex, which of course is injected. Okay, so that will be the injectable. All these aromatase inhibitors are given orally. Okay. So for the Faslodex situation, again on day 1 to 21, we will give just the Abrams only. Okay, and then for the first 3 doses of Faslodex, which are just like a loading dose, you'll be giving the Faslodex every 2 weeks. Okay, for the first 3 doses. And then after that, you'll be giving the Faslodex once a month. You know. So Abrams will be given for days 1 to 21, and then your Faslodex will be given once every 2 weeks for the first 3 doses, and then once a month, that is every 4 weeks after that. So that's the way those are used in combination. Okay. The half-life for Abrams is actually extensive. It's about 24 to 34 hours. And so that permits a once-a-day dosing of the drug. In terms of its plasma protein binding, it's about 85% plasma protein bound. And the metabolism is also by your 3A4. Okay. And then the excretion is primarily fecal. Okay, so you have a fecal excretion of about 74.1% of the administered dose, and then renal excretion is just about 17.5%. So it's primarily excreted fecally. Now, as opposed to your other topic, well, let's talk about indications. So in this particular situation, we're talking about just breast cancer. When you use Abrams with your aromatase inhibitors, that will be in patients that have an advanced or metastatic breast cancer, and patients who have not been exposed to cancer chemotherapy before. Okay. But when you combine it with fulvestrant, that will be in patients who have already been treated with chemotherapy before, particularly hormonal therapy. Okay. So if you use Abrams with aromatase inhibitors, that will be in patients who have not been previously treated with hormonal therapy or chemotherapy. But if it's used in combination with fulvestrant, that will be in patients who have had previous chemotherapy. And it's better used in patients who are postmenopausal. finally, we can just quickly look at its adverse effects, which are very similar.
Was that for the fulvestrant that you said is going to be used in the hospital?
Anytime you use Abrams, yeah, you want to use it in postmenopausal patients. Yeah. The adverse effects, just like olaparib, are also GI related and also pulmonary related. Okay, so you can have the nausea, vomiting, diarrhea, the anorexia, the soreness of the mouth. Okay. So you can see sores in the mouth and all that. Pulmonary system, it can also cause clotting. And so you can have that pulmonary embolism, within the pulmonary system, difficulty in breathing, that shortness of breath, and all those can be observed with Abrams. And it happens to affect the bone marrow. In fact, a TLT of Abrams is actually neutropenia. And so it affects the bone marrow easily. Apart from the neutropenia, it can also produce thrombocytopenia, and it can also produce your anemia. And you know what anemia can lead to in terms of fatigue, weakness, asthenia, all those things. Okay. So it can produce all of those adverse effects, and many of which you saw with your olaparib. Okay, alopecia, of course, is also one of the adverse effects of your Abrams. All right, we'll hold it there. Questions?
So I just want to clarify for the indications with Abrams is used when chemotherapy has been given, it can be used with Fasida, right? And then when it's not given, it's
Aromatics. Oh, anyway, aromatics inhibitors. Aromatics is just one of them.
Please, can you give us, can you please repeat what you the frequency of the dosing of combination
With which one?
Abrams
With aromatics inhibitors or
aromatics, yes, aromatics, but the one you say,
with for the aromatics inhibitors, you are using anastrozole, 1 milligram. Okay? If you want to use letrozole, it will be 2.5 milligrams. If you want to use exemestane, it will be 25 milligrams. You know? So you pick one that you will combine with the Abrams. And if you want to use Faslodex, that will be the injection. You know, in that situation, you'll be given 500 milligrams of the fulvestrant. And you use, for the first 3 doses, it will be every 2 weeks. After that, it will be once every 4 weeks. That is once a month.
how about the days?
For the Arimidex group, that is the aromatics inhibitors, you'll be given the aromatics inhibitor in combination with the Abrams for the first 21 days. And then 22 to 28, it will simply be the aromatics inhibitors.
For the Faslodex, is the life of the patient, how
most allowable rate. If you're getting good results, keep using it until. Yeah. Any other questions? Okay, thank you.
Technically, I was there before. But the church, they were. Actually, when I get married to church in Mexico.